Hi, my name is Uday Kode, and I am a third-year medical student from Michigan State College of Osteopathic Medicine, and I am presenting our research titled Tactical Approaches to Managing Moisture-Associated Skin Damage, Insights from a Retrospective Case Study. So, moisture-associated skin damage, or MASD, is a common but largely preventable condition that is caused by prolonged exposure to irritants such as urine, feces, sweat, or wound exudate, and it most frequently affects patients with incontinence or immobility in the sacral and coccygeal regions. The significance of this project lies in the fact that MASD is frequently underrecognized, or misclassified in clinical practice. When we fail to identify it early, the excess moisture disrupts the skin barrier, which can lead to inflammation, maceration, erosion, and a significantly increased risk for both infection and pressure injuries. Our primary aim was to evaluate MASD management using the standardized GLOBE-EAD staging system and assess the effectiveness of a consistent multimodal treatment approach in a large cohort of 185 patients. Now moving on to our methods. For our methodology, we performed a retrospective chart review of 185 patients who met our inclusion criteria and were treated uniformly with a standardized plan of care. To ensure quality and consistency in assessment, we utilized the GLOBE-EAD or Global IAD Expert Panel staging system, which allowed us to categorize skin damage based on visual appearance and the presence of infection. As you can see at the bottom of the poster in the left corner, there is a picture of each of the 4 stages that we used to classify our MASD. So our standardized treatment protocol focused on 3 critical pillars. The first one is to enable moisture absorption and to control bacterial spread. We used AMD gauze. For barrier protection, we applied Comoseptin ointment, which provides a high concentration of 60% zinc oxide barrier. And for advanced skin protection, we utilized no-sting cyanoacrylate. We combined these products with rigorous hygiene maintenance and skin separation techniques. Healing progress was then documented through regular nursing assessment using standardized outcome categories ranging from healed to worsened. So moving into our results, the data reveals a high baseline severity in our patient population. If you look at figure 1, you will see that the majority of patients presented at stage 2 and stage 3 MASD, which indicates that significant skin damage had already occurred before intervention began, suggesting a systemic delay in early stage diagnosis. The overall impact of our standardized care protocol was highly encouraging. Over 75% of patients achieved a favorable outcome, and with the exact breakdown as stated in Table 1, 52.1% of the cohort showed clinical improvement and 16.72% reached complete healing. However, the most compelling findings emerged when we analyzed the data by GLOBE-EAD category in Figure 2. We found a direct correlation between comorbidity burden and healing potential. For patients in Category 1A, those with fewer systemic health issues and no infection, we saw a 50% healing rate. However, as complexity increased Category 2B, the healing rate dropped to 0%. In this highest risk group, while 44.4% of patients still improved, 11.12% actually worsened despite treatment. This confirms that while the protocol stabilizes the skin, underlying conditions such as cardiovascular or renal disease are the primary determinants of the final healing trajectory. So, these findings lead to our unified discussion and what can this be for clinical implications. While our multimodal care plan is broadly effective, the limited complete healing rate of under 20% reflects the chronic and complex nature of MASD in patients with high baseline severity. As stated, with the stark contrast between Category 1A and 2B outcomes, suggests that for the most complex patients, success should perhaps be redefined as stabilization and infection prevention. Furthermore, because so many patients present at stage 2 or stage 3, our primary takeaway is the necessity for early intervention. And by implementing the GLOBE-EAD tool during initial admission can help identify stage 1 symptoms before comorbidities begin to significantly limit the potential for full recovery. So to conclude, I'll address an anticipated question. Because why focus on improvement rather than just healing? In this complex population, stabilizing the skin and preventing infection is a major clinical victory because that can reduce secondary risks like pressure or decubitus ulcers. By standardizing our assessment and treatment, we can significantly improve the quality of life for these vulnerable patients. Thank you for your time.